Great, well, thank you. So as you just heard, as a doctoral student in the Department of Counseling, Clinical, and School Psychology, my focus is really on working with children and families who've been exposed to different types of adversity and trauma. And today I'd like to just share a little bit about the experiences that got me interested in this topic, what I've learned from the work that I've done, and where I think we need to be headed next. So as an undergraduate, I had the opportunity to study abroad at the University of Cape Town, South Africa. And when I was there, apartheid had already been over for a little bit more than 15 years. But I was still able to see the enduring impact of these former discriminatory policies that had been in place. So in addition to observing racist interactions between white and non-white South Africans, I also saw huge racial disparities in things like residential resources, access to education, as well as rates of exposure to violence. And it was really on the heels of this experience that I began my senior year of college working in a therapeutic after-school program in Boston for children referred by the state, mostly for high rates of aggression and violent behavior. And as I got to know these kids and I got to work with them, I learned that they all had other similarities as well. All of them were facing financial hardship, all of them lived in unsafe neighborhoods, and all of them had experienced other types of traumatic events in their lives. So for example, having a father deported or a mother in an interpersonally violent relationship. I also noticed that when we got together as a treatment team and discussed cases, we rarely focused on these environmental stressors or these traumas. Really, we talked about diagnoses, medications, and behavioral goals for that week. And so it was really these experiences in Boston and South Africa that started to show me how we often ignore these larger systemic issues in favor of what we like to see as individual level problems. But if we take a step back and think about a child who's chronically exposed to experiences that leave them hurt or scared, it makes sense that they'll learn to protect themselves in different ways. Maybe they develop a lack of trust in others. Maybe they are constantly alert, anxious. Or maybe they become emotionally numb, tough, even start to fight back. And in return, these kids often get labeled as troubled or damaged. As a society, we're quick to highlight individual deficits, slow to acknowledge and capitalize on strengths, or to recognize the ways in which our own systems, policies, and practices may have contributed directly to many of the challenges faced by young people today. So at UCSB, I have continued to try to understand the impact of childhood adversity and trauma. And by now we know from more than 20 years of research that adverse childhood experiences, or what we call ACEs, have a direct, robust link on physical and mental health outcomes for kids. And when I talk about adverse childhood experiences, or ACEs, I'm talking about childhood experiences of abuse, neglect, or household challenges, like having an incarcerated parent or a parent with mental illness. So given all of this research, the important question that many researchers and practitioners are now trying to understand is how can we actually address ACEs or even prevent them? And through amazing training experiences to train at places like CALM, a community serving agency here in town, or the Parent-Child Interaction Clinic at UCSB, I've learned that we do have very effective therapeutic treatment for kids, including kids exposed to adversity. But I've also seen that only a small number of families in need get access to services. And you can imagine how some of these families most in need are facing the most barriers to care for things like finances, stigma, or cultural and language differences. So some of my research has really tried to understand what else besides therapy can promote resilience to adversity. And my research and research of others has really found that there's a range of factors that can help. There's things like good parent mental health, healthy parent-child relationships, school and neighborhood safety, even the presence of just one positive adult mentor. Even physical aspects of neighborhoods, like sidewalks, parks, recreation centers, and libraries, can make a difference, as well as the absence of things like litter, poor housing, and vandalism. And research has also supported the need for more attention to institutionalized barriers to health. In my work, I've found that although ACEs do impact everyone, they do not impact everyone equally. Youth of color are more likely to experience higher levels of ACEs and less likely to have access to some of these protective factors. Additionally, even when youth of color do have access to these protective factors, they don't seem to benefit their health to the same extent as they do for white children. And this is all wrapped up in the institutionalized inequities faced by youth of color in our country. And we see this in racial disparities, in neighborhood and residential resources, school disciplinary strategies, law enforcement practices, incarceration rates, healthcare, and more. Additionally, a wealth of research has now shown that just experiencing racism in and of itself can make us sick across the lifetime. So how can we use this research to inform intervention to childhood adversity? The Santa Barbara Resiliency Project is a partnership between UCSB, COM, and the Santa Barbara neighborhood clinics. And what we're doing is trying to examine the effectiveness of a brief intervention for parents of babies at risk of ACEs. This is an intervention that's delivered right in the clinic, ideally the same day that parents are already coming in for their well child visits. We deliver the intervention in English or Spanish, and we focus on parenting because what the research has shown us is that a warm, secure, and nurturing parent-child relationship can be protective in the face of adversity. And parents also get to meet with a wellness navigator. This is someone who connects them to all sorts of resources: food access, income, employment, housing, transportation, insurance, social services, and more. And so what we're trying to do here is resolve some of the challenges that we know exist in terms of access and care, capitalize on family strengths, and address some of these broader barriers to good health. So as we continue in this work, we must continue to inform all of our intervention and prevention programs with understanding of inequities faced by certain subgroups in the United States, as well as here in our own community. This means developing and implementing policies and practices that reduce discrimination and bias. It means capitalizing on strengths and protective factors. It means considering culture and if our interventions are aligned to the populations that we're trying to reach. And finally, community partnerships are so key. These are photos from some of the outreach that our research group has done and continue to do, because what we've learned from the work that we've done over and over again is that when academic researchers and community members can join together and share their unique wisdom and experiences, we can co-create solutions to not only help young people build their psychological strengths, but help us build the resilience of our entire community. So with that being said, I'd like to just thank you for allowing me to be a part of this community event tonight and share my work with all of you.